Hi there, Peyton Howell. I'm Chief Commercial and Strategy Officer at ParExcel, and I'm representing the Association of Clinical Research Organizations, including our work on diversity.
Great. Sam?
Hey everyone, my name is Sam Rose, and I'm CEO of Crescendo Health, a company that supports patients in contributing their data for medical research.
Okay, Joseph?
Yeah, my name is Joseph Sheeran, and I'm the CEO of the Critical Path Institute here in Tucson. For those people who don't know this institute, it is an institute which is a non-profit organization and develops drug development tools in order to speed up drug development and also to make it cheaper.
Nikla?
Hi, everybody. I'm Nikla Emambokos. I'm representing Cell Press. I am the editor-in-chief of our new medical journal, Med, and we publish throughout the clinical and translational research continuum. Obviously, clinical trials are of prime importance to us.
Nice to meet you, fellow editor. Jonathan?
This is Jonathan Watanabe. I'm a health economist and clinical pharmacist, and serve on the Forum for Drug Discovery, Development, and Translation, and worked on their real-world evidence series, which included the development of some.
Heather?
Hi, I'm Heather Zygmunt. I lead the study management team for early biopharma trials at AstraZeneca. And as a whole, AstraZeneca R&D, we're really focused on ensuring that we're bringing treatments to all patients. And that includes all populations. And that's what my interest is today.
Great. Linda?
Hi, everyone. I'm Linda Sullivan. I'm the co-founder and executive director of an industry consortium called the Metrics Champion Consortium, often known as MCC. And we work with different clinical research stakeholders to define what to measure that helps drive performance and behavior. So this is of great interest to us.
Okay, Nadine?
Hi, good morning, everyone. My name is Nadine Barrett. I am associate professor in the Department of Family Medicine and Community Health at Duke University. My focus is I'm a health disparities researcher focusing on stakeholder community engagement as both advisors and participants in research, and I develop interventions, systemic interventions to improve access and engagement in clinical research and trials for diverse populations. Good to be here.
Thank you. Lisa?
Hi, sorry, I had to step out for a minute. Can you hear me okay?
Yes.
So I'm Lisa Levange. I'm a professor of biostatistics at UNC and also about to become the chair. And I spent a number of years heading up biostatistics in the Center for Drug Evaluation and Research at the FDA. One of my focuses was on demographic subgroup representation and trying to discern whether drugs work in underrepresented populations. So, but I also run some large clinical trials as a coordinating center PI. So both ends of the spectrum, representation in the trials and how to analyze the data for subgroups on the other side.
Okay, great. Denise?
Hello, my name is Denise Baker. I'm with AstraZeneca. I'm in the Senior Director for U.S. Regulatory Policy, and I also support our CMO office. And as was mentioned, we have a very direct effort to try and engage all parties in our clinical trial and drug development.
Yes. Andrew, who just asked us to keep it short.
Hi, everyone. I am an Associate Program Officer here at the National Academies. So yes, please just keep it to name and affiliation so that way we can start to get into these discussions. Thank you.
Right. Okay, Liz?
Hi, everybody. I work for HHS.
Okay, Ashley?
Hi, I'm Ashley Atkins with the Novartis US Foundation.
Okay, and Lawrence? Okay, thank you. So we still don't have our moderator, right? Who's I sure don't know anything about this.
Pam is the moderator, and I don't believe that she is back in yet.
Right.
But I will send her a message and see if she's having any luck getting back in.
Right.
We do have discussion questions. I have the breakout group discussion questions up.
Right, and so we should probably.
Do you want to just share the screen on that? Because yeah, I think they sent us the breakout thing, so maybe just show that.
And then we probably need someone to take notes, right? We have to report back. Is that the?
You want to just type it right on that Word doc?
I don't, but someone can.
Can you all see the discussion questions that I'm sharing?
Yes.
Yeah.
Yes. Okay.
Do we just want to go through them and then, since we don't have much time, and then we could just jot down some notes?
Sounds good.
Andrew, do you want to, can you zoom on that a little bit? Maybe just so that way it, my poor eyes. So we just read it off. So I guess discussion questions for session 1, enhancing outcomes in a more person-centered and inclusive clinical trials enterprise. The following are potential goals related to enhancing outcomes in a more person-centered and inclusive. Well, briefly comment on these potential goals before moving to discussion questions. So we're talking about improving representation and relevance, improve community engagement, transparency, and user-friendly to foster trust, counter misinformation and meet the needs of patients, demonstrate the clinical trials, and engage a research workforce. Do we agree with these goals? If not, what would you change and how? I could just say one comment, right? Because I'm right in the heart of at UCI. We have a mass vaccination clinic that we're using our basketball arena to do, and one of the major issues just seems to be accessibility to the public for scheduling their clinic visit so they can get the vaccine. So I think that's when it comes to clinical trials access and pragmatic clinical trials access is just making sure that that access is easy for broad sections of the population. It's not easy even for those that have a college education and a smartphone. So I think that just ensuring that we've got ready access so patients that we want in these trials are available. I think we still have a long way to go.
I was struck listening to our first speaker, Dr. King. On the one hand, as an African-American woman, I saw myself in his remarks in terms of my health conditions, diabetes, high blood pressure. You know, I'm average weight, I exercise, but yet I still have all these problems that people who are low-income African-Americans have that might affect, you know, my vulnerability to COVID. But I just want to briefly comment that I think that one of the dangers, one of the cautions we need to undertake as we seek to improve representation and relevance and engage communities is that we not overly stereotype our own communities. Like I was struck that, you know, the idea of the barbershop, the church, and the beauty parlor. I mean, many African Americans don't live lives that are centered in those institutions. We have to make sure that we don't miss people by allowing a common narrative about where Black people are and who they listen to become definitive. We need to be actually, I think, a little bit more realistic and open to a broader understandings of how one captures the trust of minority communities. And if I was having that reaction to Dr. King, I could imagine that other people who belong to minority groups were feeling like, well, what's the model for reaching us? This isn't going to even reach all African Americans. How's it going to reach Hispanic Americans and poor white people in Appalachia and Native Americans and new immigrants? And I mean, there's all these groups that we need. I think he's absolutely right that we need to rethink our models, but we also need to rethink our rethinking of the models and not rely upon traditional tropes and categories.
I wanted to add that what I think it would be, so I do see about overgeneralizing, but also having broad clinical, like a large clinical trials. There's limited resources in terms of diversity of populations. If we are tapping them constantly with smaller clinical trials, that sort of leads to people fatigue, and having more consolidated or centralized clinical trials might be something to think about also for numbers.
So one of the things that I thought might be missing from this is the whole area of the need to maybe expand the clinical research infrastructure. And what that means in my mind is in part that we have to reach out beyond academic research institutions. We have to connect with healthcare providers in the primary care setting and be open to having, naive investigators. And how do you support naive investigators? So yes, we can try to engage and prepare a diverse workforce, but there's other things that really need to be in place, because otherwise sponsors will continue to just go back to the same places. So we don't want to get in a situation where we're encouraging everybody to do various things, but then they're not rewarded. They don't get selected as sites, or we start to engage new sites and we let them fail. I think there's a new support system that's going to need to be invested in here, and that the clinical trial enterprise has just got to expand.
Yeah, I think that there's also one thing which is missing in my view, because this is more for the bigger trials. And there is a lot of work going on in rare diseases, which have much smaller trials, and also the new treatments which are becoming available, like in the gene and cell therapy, which are quite moving fast ahead. They may need a very different setup in order to be able to conduct these kind of trials. So I missed that in here as well.
And I'm sorry, this is Pam, so I'm back, and I don't know if somebody took over the moderator job, but it looks like you guys got started. Is there a rapporteur? So just so that I know we are on track for reporting out, did you guys figure that out? And I'm sorry, I don't know what, my whole computer crashed in the end. So is there somebody who was going to report this out? Because that was one thing we were supposed to do at the beginning. It sounds like you got started on the first section here about whether you agree with the goals and what to change. So that all sounds really good points that you've been bringing up.
Hi, Pam, this is Andrew. We did not appoint a rapporteur, but I've been taking notes. So if someone wants to volunteer for that role, I can send them the notes that I've been taking.
I'd be happy to do it. I started typing as well, so I've actually jotted a few things down. So yeah,
Perfect.
That's to keep things moving. I'll volunteer.
And sorry again, we were assigned about 10 minutes per question, so this was the first one. Did everybody have a chance to sort of chime in on some additional points around these goals? And are we ready to go to a next question? I know you got a difficult start to the session, so we might want to just add a few more minutes here, and then kind of move maybe to the next question at like in 4 minutes, just so that we give this a chance.
Yeah, I just have one more comment here. So building on a couple of the previous statements, when we talk about the supporting infrastructure to be able to expand the representation of our interventional trials. There's a lot of work to be done to better understand the natural history of these communities. And so one of the tactics that we can deploy to support both understanding the health of these populations, the levers to potentially improve it, and to engage with them more effectively and make those studies more representative when we get to the interventional stage, is to make it easier to spool up lightweight registries that help us to understand what is going on in these communities, particularly those that are impacted by many of the social determinants of health challenges that can meaningfully impact the health outcomes and access to clinical trials.
Thank you.
And I'll just add one build that I think is missing from here is when I'm looking at this, I'm seeing a lot about trust, but really, do we know why only 3% of the population participates in clinical trials? It could be other things. And I strongly believe that we should be getting to a point where not just that clinical trials are used as an option for care, healthcare, but also that patients can choose how they want to participate in a clinical trial. So if I want to go in to see the doctor, I can. If I want to participate on my phone, I can. If I want to go over to, the local LabCorp, as opposed to driving all the way into the city that takes me 2 hours, I can. And so I think perhaps something, that goes something in, it's not just about preparing a diverse clinical workforce or making sure that we're ensuring, training sites. It's all about almost reevaluating the construct of how we design clinical trials or implement clinical trials.
Yeah, I think that is an important part as well. You're right on that. I'm trying to think if some of those things fit in other places though, but I think they're good to bring up, and then afterwards we can sort of reassign them to the different areas that this vision is looking at. Are we ready to move to sort of the next question as far as what are some interim actions that we could think of to take that will be critical to get to 2030 if we want to get this accomplished? And I do think the world looks a little different and might have accelerated a little bit, hopefully, compared to what we thought where we'd be at a year ago. But Andrew, is that your screen that you're sharing? And thank you for that. Could you move that up a little bit so we can see the question? But the question is, what are some interim actions, short-term actions and milestones that we should address within the next 5 years so that we can kind of get ourselves to 2030? And then what are the stakeholders that are needed to effectively carry out those activities? I mean, I think, Sam, you mentioned those communities that we need to think of. So are those some stakeholders that we need to engage with?
So I think that one of the things that we can tackle is, can we work with academic partners that go beyond the kind of typical marquee institutions and are much more geographically dispersed to support registries of communities that really represent the public, and through that better understand what are both, first of all, the health challenges that are impacting these communities, and what are the existing levers and interventions that can be used to promote health with these communities. It almost starts with a hybrid of population health and observational research. And then once we've got those frameworks established, that very same infrastructure can be used to support identifying patients to bring into clinical trials, leveraging that observational infrastructure to and the PIs that are leading it to support with these interventional studies that the industry is more interested in. So I think that to Dr. King's earlier point, we've got a lot of work to do to beyond bringing the next innovative therapy. There's a lot more basic health needs and disparities that need to be tackled first. And I think investing in the systems to better understand those and basically bring up the equity of the way that we're providing care before we start talking about experimental interventions.
might add to that, and I apologize, I joined late and I may be repeating things that have already been said. But I think, in fact, we've talked about investment. There has to be an investment in the community and connection with that community. The CTSAs do it, but if you're coming in to do science on them, it's not going to be well received. To be able to show the benefit, to invest even, quite frankly, in the very poor science infrastructure, reaching out to the schools and to other resources available in these communities is one way, in fact, that you can show goodwill and benefit, that people start to appreciate how engaging in clinical care is, in fact, a potentially worthy scientific process where they get individual value for themselves and their community.
Yeah, I think maybe this idea of investing might be something to sort of think about, because Peyton, you also mentioned investing in diverse investigators and sites. I mean, it feels like we sort of don't invest in anything but expect a lot of return on things. Kind of, can you maybe elaborate? That's my personal paraphrasing on things.
Right. We've done this on a couple of specific studies, but to actually build a network of community sites, right, where there's an investment in diverse PIs, often new to clinical research, out in the community, so that what Sam, Linda, and a few others were highlighting, I mean, that could be really something intentional that could show quick action. And in this world of COVID, actually is really needed, as we need to do more research outside of those main centers.
So investment by 2025, and sort of maybe putting some additional, that seems like a really good action item that would move the needle, it feels like. Is there anything else on the investment point in something else that needs investment, or is there another thing we can sort of think about?
Yeah, this is Nadine Barrett from Duke. I think one of the things that really stands out to me, and I think it's really kind of piggybacking on what others have said, is this idea of COVID has shown us just how much our community partners and organizations play in increasing diversity in clinical research and trials. We have community health workers from community-rooted organizations and community-based organizations that are playing a critical role, both uptake in terms of screening, but also in terms of vaccine and clinical trials participation. And I think it's something that we've known for a long time, but we just don't invest in our community organizations or create opportunities where institutions can invest their money, like they get the funds, and then also invest it in the community in an equitable way. And so I think that that's another short-term goal that we could really start exploring, is how do we really use our funds and think about funding and promote ways in which we can really leverage the skills and expertise that the community has. And that's another way of bridging the trust and trustworthiness goal that was mentioned above as well.
Yeah, and I think we're at 11:55 here, or 55, which means we're going to be kicked back to the general session. So Jonathan, I know you said you were going to be the rapporteur. We didn't quite get to the long-term actions, but I think even if we had the initial, what might be missing, what could change a little bit with the goals, and then the short-term interim actions, that might not be a bad place to start as a report out. It's very actionable. So Andrew, are you going to kick us back to the general session, or how does that work? And again, I apologize for the super hard start to the session. The next one hopefully will go a little better.
Yeah, it's one of those technical difficulties. We will automatically get kicked back. I think we'll get a 2-minute warning before that happens. So.
Oh, on the agenda said we were going to go back at 11:55. I heard from some other people that got kicked out of sessions, so maybe they're giving us a little bit more time. Is there other things we should address in the next 5 years?
I had a suggestion that I'm interested to play off of all of you, which is there's a lot of what we've been talking, I'm trying to figure out how to scale. So we've been talking about smaller things within communities, which I think is important, but is there another way to scale that? Is there, a pharmacist, so patients trust their pharmacist, so they don't mind going to the local Walgreens or their local CVS, and then we partner with CVS to utilize that network. There's something, I think, from the longer term perspective that we need to consider of how do we do this investment in the community at scale?
Yeah. And now I'm getting a message that we're going to get kicked back in 40 seconds. So anything else? I think the scaling is, I think there's individual activities that have happened that worked, but it's so hard to scale any of this.